Hello, everyone, and welcome to a chat with Dr. Fionnuala Barton, who is based in the UK. And Dr. Barton is a menopause specialist. She's a women's health doctor and registered member of the British Menopause Society, amongst a ton of other things. She's very passionate about optimizing your health physically and emotionally, so women at all stages of life, and has a particular interest in early recognition and management of perimenopause and menopausal symptoms. So without further ado, welcome, Fionnuala.
Hello, Christine. Thank you for having me.
You're very welcome. It's lovely to have you here and chat with you again. So you have a huge amount of knowledge, but today we're going to chat a little bit around the ladies out there who have gone through a form of cancer and then maybe have symptoms following on from their treatment, which look like they could be menopausal, because often with treatment, women can be pushed into what's known as a chemical menopause. So could we start with you just explaining what chemical menopause is to everyone out there?
Yeah, absolutely. So obviously menopause is a word that we use to describe, a stage of life for women. Officially, it's when a woman hasn't had a natural period for 12 months. Now, that on average happens naturally to women in their sort of late 40s and early 50s. But if women go through treatment for certain cancers, and in particular breast cancers, if there is estrogen positive receptors in the cancer, then one of the strategies of treatment is to try and block the effect of estrogen on those cancer cells using medications that will essentially either block estrogen being produced or block the effect of estrogen throughout the body.
So with that, we're talking like tamoxifen and Femara and
so aromatase inhibitors or tamoxifen.
Yeah.
And what they essentially do then is starve the cells of the body of the the estrogen that it needs. And thereby pushing those women into an unnatural menopause or a chemical menopause. It's a menopause, a stopping of periods that's happened due to influence of chemicals or chemotherapy or in some cases radiation as well. It can be enormously debilitating, whereas natural menopause will often be something that progresses gradually over time and causes problems. A chemical menopause might happen quite quickly, quite dramatically. And of course, it's often in the context of a cancer diagnosis, which in itself is enormously stressful and traumatizing. And so a lot of women find actually that the symptoms they experience are almost doubly worse because of the context in which they're then starved of that really important estrogen. But the symptoms are very similar. Often with chemical menopause, the hot flushes and the vasomotor symptoms and the sweating symptoms can be, enormously debilitating, profoundly destructive, particularly for things that like sleep. And of course, if you're not sleeping well for whatever reason, but hot flushes and sweats being one of them, then that has a huge impact then on your day-to-day life thereafter.
Yeah. So some women, if they are obviously unfortunate to get cancer at a younger age, may then experience this sort of chemical menopause at a very young age. But it is reversible, is it not? If it's someone experiences very young, in some cases.
Yeah, so it kind of depends on the circumstances in many ways. So if you have a young woman who's being treated with chemotherapy and radiotherapy for an estrogen sensitive cancer, then they will experience that chemical menopause quite early on. And there is distinct possibility that that is reversible, that when they stop their cancer treatment and then when their body sort of recovers both from the chemicals themselves, but also the physiological stress that they've been through, some women do regain natural menstrual function again and natural ovarian function, and they might go on to then have periods again. What often happens though is that they will then hit their natural menopause slightly earlier than expected as well. So, for example, if you have a woman in her mid-30s or late 30s who has breast cancer treatment, she might reestablish periods in her mid-40s, but they then might stop early or earlier than that kind of natural age of menopause around the age of 50.
Yeah. And for those that obviously are unfortunate enough to get their cancer late 40s, but have had regular periods before and are then pushed into their menopause, it's very unlikely they actually go back to getting their periods. It's not impossible, but it's unlikely. And then they start getting those symptoms. So I just wanted to quickly mention here that obviously pillars of health are extremely important. So managing sleep, making sure you get enough sleep, and having a very nutritious diet, and not one that is avoiding too many things, but making sure it's nourishing the body, because avoidance can obviously put another stress on the body. When, you know, I see people that are like, oh, sugar, I shouldn't be having sugar. Well, it depends where the sugar's coming from and how much is being consumed. But a nourishing diet is really important. Exercise, as you and I know, has been proven to reduce the risk of cancers by something like 50%. And obviously, social relationships, so making sure that you have the support around you, and getting, you know, moving away from anyone who is unsupportive and negative towards you, because that's extremely important as well. But obviously, when people have those in place, they still may be getting things like huge amounts of anxiety, brain fog, which I have seen in clinic like nothing before, you know, huge amounts of brain fog in the late 40s. And of course, it can obviously be from the medicine that's still in their systems and it needs to get out. Osteoporosis has been triggered, and all these things that women often experience sort of post-menopausal are happening to these ladies at a much younger age. But there are things that they can actually do, aren't they, and take to support them that isn't necessarily hormone related. So I think that's why we want to move on now. There are things that they can do to support themselves without thinking of HRT.
And there are, and I suppose it comes from, if you stand back and think about why it is that these women are struggling so much, it's multifactorial. It's because they have had a cancer diagnosis, which is enormously stressful. They're having potentially surgery, chemo and radiotherapy, plus minus steroids or other medications that can cause enormous physiological trauma and stress themselves. You're then on medications that are reducing natural hormone levels, so you're plunged into that kind of early menopausal situation, and all of the symptoms that you're experiencing lead to perpetuating worsening symptoms. If you're not sleeping, you're not going to have the energy to perhaps motivate to exercise and to eat well and all of those sort of things. And so there's a lot of pressure on these women actually to be doing the right thing in circumstances that are actually very difficult. And I think more than anything, the one take home I want people to have from this conversation is that there are lots of things that women who've experienced a cancer diagnosis can use safely. And going back to your earlier point about connections, it's really important to make connections with people and to speak to people who can support you from a medical perspective, but also people who can support you from a peer perspective, because that will make you feel less isolated, alone, and also share ideas. But going on to what the options are, and again, it kind of depends on what treatment people are being put on, whether they're experiencing difficulties whilst on their treatment, or this is difficulties after having finished treatment. So for women who are experiencing problems on their treatment, either on tamoxifen or aromatase inhibitors, so things like exemestane or anastrozole, one of the things you can talk to your medical oncology team about is whether actually you might be better on one of the other medications, because some people just do better on one versus the other. And obviously the most appropriate of those medications is dependent upon age. It is dependent on age, stage, grade, and aggression of tumour, and sort of, I suppose, outcome that they're aiming for. The other thing you mentioned is osteoporosis, and what's really interesting is there's been a subtle shift in terms of the use of bisphosphonate medications. So bisphosphonate medications are these medications we use to help maintain bone mineral density in women who have a risk of osteopenia or osteoporosis, and we don't normally use them until above the age of 50 in sort of women who haven't had a cancer diagnosis. But there's increasing use of bisphosphonates early alongside aromatase inhibitors, for example, and tamoxifen, to try and improve or reduce the risk of the bone mineral density loss as a result of being on these cancer treatments. And so that's really important to bear in mind. And if you're not on something for bone health, maybe talk to your oncology team about whether it's appropriate for you. They may well have made the decision it's not right for you as an individual. And there are lots of different sort of reasons why that might be. The other thing that's really important to consider are the SSRI and SNRI medications. So often overlooked and bizarrely very much stigmatized still in the menopause and perimenopause space. Everyone's pushing to have HRT because it treats things at the root cause. And I would agree with that by and large, but don't forget the impact of lifestyle. Much of the symptoms we experience during perimenopause and menopause, when it's a natural process, are actually due to the metabolic shifts that we're experiencing too, and can respond really well to that lifestyle approach. But if that's not necessarily something that's available to you or easy for you to achieve, then using something like citalopram or sertraline or venlafaxine can be a really useful thing to help you sleep better, help manage some of the anxiety you might be experiencing, sometimes help to actually dampen down or change some of the hot flush symptoms that you're seeing. So venlafaxine in particular has actually been licensed for use in menopausal hot flushing, not just as an antidepressant, because it's been shown in trials to be really effective for hot flushing symptoms in women who can't use HRT.
That's really useful to know. And also to just point out that ladies who might sort of want to go that route, they're not addictive, and they can take them for a very short period of time, just sort of to get them over the bump in the road, get them through.
And to enable you to stay sort of coping and able to sleep and things like that during a period of quite difficult time. The other group of medications are the gabapentinoid medications, so things like gabapentin and pregabalin, designed as anti-epileptic drugs, but actually in more recent times we use them very frequently for pain relief. So if you've got pain as part of your menopausal syndrome, a lot of women who have a chemical menopause will experience profound and uncomfortable joint pain, as well as all the hot flushes and anxiousness and sleeplessness. Gabapentin can be a really useful tool in these women. Again, it's not addictive. It is a drug that is high risk for abuse, so it's got quite high street value, which is why people don't like prescribing it very often. But in this particular group of women, it has enormous value. There is also some evidence about using things like oxybutynin, which is a bladder drug. Actually, it's used to treat an overactive bladder, but it has been shown in some trials to be beneficial at treating some of the other menopausal symptoms that we see in both chemical and natural menopause. So there are a few more options. It's not just HRT or SSRIs or nothing. There are a few different things from a medicines perspective to consider. And I just, as I said, I want people to know that there are options. They don't feel like they're completely alone and without any options available.
Yeah. And also the things, naturally that they eat through, like flaxseed oil, has been known to also improve both progesterone and estrogen naturally in the body without pushing it to levels that are going to implicate their health. But I don't know, some women aren't aware that we have estrogen receptors in our brain. We have them, so they're not just in our boobs and our sex organs, they're absolutely everywhere. And that's why so many of our tissues get affected when we have a lack of estrogen as well. So getting estrogen in through other ways naturally that are modulators rather than, they're not a hit of estrogen per se, they are much more natural, could also be another way to support health.
Yeah, it is careful that you do need to be careful about, again, that distinction of whether you are postmenopausal, having completed your breast cancer treatment, or whether you're still on treatment, because there is some recommendation to try and avoid too many sort of phytoestrogen rich foods when you're using certain chemotherapy agents. Again, if you can talk to your breast care nurse or your cancer care nurse or your oncology team, they'll be able to talk you through that in a bit more detail. The problem is we don't have a huge amount of research in this area, because the ethics of researching is already a very vulnerable group of women, but we do have lots of observational data. So a lot of the information that we've got isn't necessarily coming from high-powered randomized control trials, but yeah, finding natural ways through is definitely it's definitely feasible. Actually, moving from that point about estrogen receptors being sort of all over the body, in particular, we've got lots of estrogen receptors in the urogenital tract, and so bladder symptoms, vulval and vaginal dryness, discomfort during intimacy, and then loss of libido and painful sex and things, they're really common actually in women who've gone through surgical or chemical menopause, and they can be very notoriously difficult to treat. So there is some interesting research going on at the moment about whether we can safely use vaginal estrogen treatments for women who've had estrogen sensitive cancers. And there are a lot of specialist clinics actually prescribing estrogen to these women, because in theory, the estrogen that you absorb from a vaginal estrogen treatment is so low that it isn't necessarily going to have a significant systemic effect. So again, talk to your prescribers, your oncology team. Again, it depends on grade and stage of tumour and risk of recurrence and such like. but it'll be interesting to watch that space.
That's
It's
very
also important.
interesting.
There's a medication called ospemifene, which for some reason hasn't yet had a huge amount of use in the UK. It's an oral selective estrogen receptor modulator, and it's again been designed to help treat the urogenital symptoms and vulvovaginal symptoms in women who can't use estrogen therapy. It's an oral tablet, and we have it sort of fourth or fifth line for treatment of menopause related vulval and vaginal disorders, but obviously that can be used much earlier in women who in whom estrogen isn't a safe treatment option, or if you're concerned about recurrence as a result of a previous cancer diagnosis.
Right. And before then, there are some very good non-toxic lubricants that women can use as well at, any stage going through this.
Absolutely. And I think that the range that's coming available is ever increasing, frankly, which is great news, because I think historically we only ever had really poor options available. But yeah, so do your research and look for options that work for you. It does often involve an extent of trial and error. I know Silk is a brand here in the UK that have done a lot of work making sure that their products are super safe for anybody who's been through a cancer diagnosis that means estrogen isn't an option for them, and they've got products that are useful both as moisturizers and lubricants.
So the big take home is to keep asking and to not just take the first thing you're prescribed as the be all and end all. If it's not working for you, go back and ask for something else, or to try something else. I just want to touch on the subject of checks, because obviously the cancer seems to be coming at an earlier and earlier age, unfortunately. And there are, we're in the south of France, you're in the UK, and there are services provided where we can go and get mammograms and can get cervical smears. But still, there is a lot going undetected, and a lot of women aren't making use of these services. So breast checking is a must to be doing regularly. Do you want to tell the listeners what they should be looking for, the changes they should be looking for in their breast tissue?
Yeah, so from a breast health perspective, I think, if you're regularly self-examining and you know what feels normal for you, then you're going to notice if there's something that feels unusual. And if it's unusual and it goes and it persists throughout an entire menstrual cycle, if you're still having menstrual cycles, or if it's a persistent change, then it warrants review, irrespective of what the specific symptom is. But obviously things that we worry about include lumps, focal lumps that you can feel that are new or that have changed or increased in size, any nipple changes, so any discharge or bleeding from the nipples, any inversion of the nipples. Also, more subtly, sometimes women will just see a change in the skin texture over the breast, and what we call peau d'orange, or dimpling like the surface of an orange. Or sometimes it can be more subtle than that. It can just be a change to the skin or a persistent itching sensation over a particular area of the skin. Then you also need to be aware of the tail of the breast, so the part of the breast that goes from the front of the chest all the way into the armpit. And examine all the way along that when you're self-examining yourself, and have a good old dig around in your armpit, because that's where the lymph nodes are that drain the breast tissue, but also along here above your clavicle. So if you notice any lumps or bumps here in the armpit, in the breast, or any of those other symptoms I just mentioned, then get yourself to a doctor to get checked. They can obviously then refer for mammography and ultrasound depending on what's necessary, and biopsies if they're needed.
And treatment earlier is better than later.
And actually, breast cancer is never a good thing that diagnosis is never a good thing to receive. But the advances that we're seeing in breast cancer care currently are really quite impressive, and outcomes when you detect a cancer early can be really positive. It's a horrible journey to have to go on, but there, as I keep saying, there are options. And like I said, talk to your oncology team about whether different chemotherapy options are available to you, because there are a range of things that are available to most women. Think about the non-HRT pharmacological options, antidepressants, gabapentin, etc. Think about the natural and then prescribable treatments for vulval and vaginal atrophy. But also for some women, actually HRT may be an option, and so it's also worthwhile talking to your doctors about that. So depending on the receptor status of breast cancer, some women can use HRT if they're willing to take the potential risk. And the final thing I want to say is that historically, I think we're very worried about things like ovarian cancer and HRT as well, but the data doesn't really support fearing HRT in the context of ovarian cancer. So if you've had an ovarian cancer diagnosis and have had to have surgery, so you've gone through surgical menopause because the ovaries have been removed, then it is worthwhile speaking to a menopause specialist, because you may have options, HRT options alongside all those alternatives that I've discussed.
Now, that's not as easy to detect. So very quickly, some symptoms that ladies, I mean, they could obviously be other things, but it's always worth going to get them checked. But
I think that's the tricky thing with ovarian tumours, is they can often present quite late because the symptoms can be quite vague, and they're happening often at a time in life where we've got lots of other stuff going on. It can often mimic IBS. So there's some guidelines that say if you've got new onset IBS symptoms over the age of 50, we really need to be considering whether there might be an ovarian growth there as a result that's causing those symptoms. So things like bladder irritability, irritability of your bowel, bloating that's persistent. So rather than just bloating after a meal and then it's settling, if you're persistently bloated, if you've got lower abdominal or pelvic pain, discomfort during sex, any abnormal bleeding either between periods or postmenopausally or after sex, for example, needs to be investigated, because they can often be symptoms indicative of an ovarian problem. Also low back pain, or kind of a dragging low pelvic pain that's kind of pushing down, but also more non-specific symptoms like fatigue, and just feeling absolutely exhausted all the time with no obvious other reason. So as I said, they're all quite non-specific and vague, and actually can often be, put down to other things. But if if you're worried about it, the safest thing to do is go and ask a doctor to have some checks done. And actually there isn't a great screening tool for ovarian cancer. So even CA-125 blood tests aren't particularly sensitive or specific. So it would really require referral to specialist care in order to have adequate investigations arranged.
Yeah, but don't ignore, ladies.
Don't ignore, no. And as I said, any irritability of your bowel or bladder over the age of 50, actually it's really important that ovarian tumours are a part of that list of differentials in terms of diagnoses.
Okay, great. Any final things you'd like to say to listeners out there? I mean, I know if they want to get in touch with you, you are seeing people in London or when they're in London. So, and they can find details about you on the menopausemedic.com. Is there any other notes you'd like to say to any listeners out there?
I suppose it's just at a time in your life, if you've been through a cancer diagnosis, you're on treatment or you've completed treatment, you've had control taken away from you. You've had something happen to you that you've been out of control of, and that can often be, really difficult to come to terms with. So as well as all the lifestyle issues that we've talked about, the pharmacological and non-pharmacological treatment options, I think it's really important to have connections with people, but also to ensure that your mental health is being well cared for, and maybe thinking about some talking therapy, because not only can it help you to come to terms with the trauma and grief that you might experience around this kind of a diagnosis, there's also an enormous evidence base that it can help with things like hot flushes and insomnia symptoms during this phase. So, pay attention to the physical things, obviously, but also really pay attention to mental health and think about proactive, CBT and psychotherapy as well as options. Great. Thank you so much for your time, Dr. Fionnuala Barton. So everyone, you can check her out on her website, www.themenopausemedic.com. Yes. All right, or on Instagram, where I am at the Menopause Medic. Yes, and there is loads of free and very, very interesting information that you put out there almost daily. Almost, yeah. Okay, thank you so much. You're welcome. Take care. Bye-bye. Bye-bye.